Okay, good morning, everybody. It is a great pleasure for me, on behalf of the Norwegian School of Sports Sciences, to welcome you all to this trial lecture in partial fulfillment of the requirements of the award of Doctor of Philosophy in Sports Science. My name is Elin Kalle. I'm the pro-rector here at the school, and I will chair the two sessions in the auditorium. In particular, I would like to welcome the members of the examination committee, Professor Kari Bø, Norwegian School of Sports Sciences, Chair, Associate Professor Sophie Sonnesson, Department of Health, Medicine and Caring Sciences, Linköping's University, first opponent, and Professor Christian Samuelsson, Department of Orthopedics, University of Gothenburg, second opponent. Furthermore, I welcome the candidate, Anouk Urhausen, who will give the following lecture: Maximizing Athletic Health, Evaluating the Effectiveness, Methodological and Interventional Quality and Implementation of Exercise-Based Sports Injury Prevention Programs. Over to you, Anouk.
So, some of you might think it's a really long title, and I agree. It's a really long title. So, evaluating the effectiveness, methodological quality, and interventional quality, and implementation of exercise-based sports injury prevention programs. So it's not only long, but it also has a lot of complex words, and we will start with defining the most complex of them. So by evaluating the effectiveness of the sports injury prevention programs, I interpreted it as to evaluate the effect of the programs on injury prevention under real-world conditions, so not under ideal conditions. The methodological quality. This can be defined as the extent to which research is conducted at its highest possible standard. So to evaluate the methodological quality of those effectiveness studies, I will evaluate the risk of bias of the outcomes. So we will see how much we can trust those outcomes. The interventional quality. To evaluate the intervention quality of the programs, I will look at the quality of how the programs are reported. And then implementation. This is the extent to which the program is transferred from research to practice. To evaluate the implementation of the programs, I will look into the knowledge translation of the program to improve health. As knee injuries are one of the most common and burdensome injuries, especially in the young and active population, I will focus on acute injuries in this presentation. So overall, the focus will be on maximizing athletic knee joint health. And this is still a lot to cover, and can seem to be a lot and a little bit advanced for students. And I will apologize that the start of the lecture is maybe a little bit more condensed, but this is the title I have to present, and I will try to manage you through. So first we will look into the concept of prevention. We will look into the effectiveness of the programs, the methodological quality of the outcomes of the studies, the quality of the reporting of the programs, the knowledge translation of the programs to the implementation, and then we will conclude. So why does prevention matter? Here you can see the happening of an acute knee injury. And more specifically, she just ruptured her ACL, so the anterior cruciate ligament. And sports injuries have significant long-term consequences that we have to address. They result in physical and psychological health issues and are a burden on public health care on a society level. The good thing is that we can try to prevent such injuries. And here we'll see a typical injury mechanism. Not this one. So the knee was collapsing into a valgus, and this is how she ruptured her ACL. So prevention is better than cure. It is the low-hanging fruit that can help us to reduce the burden from the injury by avoiding that it happens in the first place. How does prevention work? So this is the sequence of prevention model von Wachen-Mechelen. It's very old, but still illustrates quite nicely the process of injury prevention research. And the process can be divided into 4 steps. The first phase involves establishing the magnitude of the problem. So in other words, is there a problem? And for the case of knee injuries, we know that's a common, very burdensome injury, especially in the young and active population and in athletes who are active in pivoting sports such as soccer, handball, and basketball. Then the next question becomes, what are the causes of injury? So to design an effective prevention program, we need to understand the most likely causes of an injury, so we know what we have to target the prevention on. And in case of knee injuries, the origin is quite multifactorial, but we know that a common injury mechanism is the knee valgus, when the knee rotates inwards. And then once the causes of injuries has been established, step 3 involves introducing an intervention method, such as an exercise-based prevention program. And then we need to assess its effectiveness by monitoring the injuries. And this is preferably done in randomized controlled trials where the effect of the program on injury incidence can be tested. And then Finch, she extended the model to translate research into prevention practice, the TRIP model. She argued that it's not sufficient that the program is effective, but it also has to work in real world. So to translate the research into practice, we need to understand the context and how it was implemented, and then to evaluate if it works in real life. So no injury prevention program will work if it's not implemented. And the last 3 steps are the ones that we are going to address. So let's start with looking at step 4. What is the effect of the programs? And let's start with looking at the studies with the highest quality that assess the effect of prevention programs on acute knee injuries. Let's look at meta-analysis. And up until 2019, many meta-analyses on the effect of prevention programs for knee injuries have been published. And here only the studies that focused on ACL injuries. And most show a protective effect of the programs, but the effect varied quite a lot from 0 to 60% of reduction in injury rate. And since then, new studies have been published. So I decided to focus on the last evidence within the last 5 years, and I will only look into a meta-analysis of randomized controlled trials that assess the effect of prevention programs on acute knee injuries. Here are the results from one study that estimated the effect only in reducing ACL injuries. And there were no limitations in age, sex, and sports, but 6 of those 8 studies included football players. This is a forest plot. So a rate ratio below 1 suggests a protective effect, meaning that the knee injuries occurred less frequently in the intervention group compared to the control group. And the further it's away from, it's below 1, the stronger the effect. And if the confidence intervals does not include 1, we can be more sure about a significant effect. And you can see that most studies show a protective effect, but also the confidence intervals are quite large. If we look at the overall effect that is calculated of all the studies, we can see that this is significant, and it favors the intervention group. So it reveals a statistical reduction in ACL injury incidence, and it was 53%. The author concluded that plyometrics, strength and agility exercises are important components to include in the program. And plyometrics are most explosive exercises. Balance was not included, and this is due to this study, who only looked at balance exercises, and you can see that the effect was not protective. The next study assessed whether injury prevention programs that include plyometric exercises have an effect, and they only included ACL injuries, and again, no restrictions on age, sex, and sports. And the overall effect showed a protective effect, as you can see here. So by doing the programs that include plyometric exercises, we saw a 60% reduction. The authors also compared the effect between women and men, and they found an even higher protective effect in men than for women, so there seems to be a sex difference. This study evaluated the effect of prevention programs also again on ACL injuries in only women football. And there was a significant reduction when they only looked into studies that had multiple training components. If they included, once again, the study that only had 1 training component, and this was balance, we can see that there was no protective effect. So there's evidence that multi-component programs can help to reduce ACL injuries by 45%. And then the last study here, the study we saw before, assessed different programs. In this one here looked at the most appropriate program. And only football players here were included across all age and for different sexes. And the negative ratio indicates, one again, that the program is associated with lower odds of the ACL injury, and the further away from zero, the stronger the association. You can see different programs, PEP program from Australia, knee control from Sweden, FIFA Plus, that was derived from FIFA 11. In Norway, we have the core training, combined training, balance training, and FIFA 11 Plus kits. And you can see the strongest effect here was for FIFA 11 Plus and for the knee control. So overall, the reduction was 46%, and they recommended to use the program, and the best effect was shown for FIFA and knee control, and I will come back to this later. So does it matter if we do the programs or not? We have 4 randomized controls who look at the compliance with the exercises related to injury rate. And here's an example from Silvas Granelli, and she here presented compliance on the x-axis and injury on the y-axis. And you can see that those who were most compliant, the high compliance group, they had a lower injury rate. So yes, compliance matter. The prevention program has probably to be done to have an effect. So overall, we can say that all the meta-analyses we saw showed a good effect, and they can be classified on the right side of this graph. Effectiveness refers to the performance under real-world conditions, while efficacy can be more defined as the performance of an intervention under very controlled and ideal circumstances. But this is not a dichotomy, it's more a continuum. And in effectiveness trials, an intervention has to be very robust in several conditions. For example, the participants should be from a heterogeneous group, so they have to have different ages, different sports, different performance level to be more robust. The setting in an effectiveness studies covers a large area, so for example, numerous clubs and not just one school. They should not be limited geographically or socio-economically. And they can also be here tested, for example, patients can be tested at training facility and not just at the research facility. Then the flexibility of intervention. So effectiveness studies should also allow for certain flexibility. For example, coaches can decide when to progress to the next level, or providers who deliver the implementation, they are not from a research setting and they are not experts. And then clinical relevance, for example, that the duration of the warm-up is more realistic. Who can we generalize the findings to? So when we now look at all the studies that we included, most studies included women. The sport was predominantly football, less basket, volleyball, or handball. The age, most studies included adolescents, people who were under 18, and the intervention duration lasted between 6 weeks and to 1 entire season, mostly 1 season. So the programs work, but the programs are still a black box in the sense that we don't know which component is responsible for the observed effect. But we know that the programs work when including several components, and we know a little bit better which component to include and which component we shouldn't include. And overall, our findings also align with the clinical practice guidelines from 2018, and they concluded with clinicians should recommend use of exercise-based knee injury prevention programs in athletes for the prevention of knee and anterior cruciate ligament injuries. Okay, let's look at the methodological quality of those studies. What is bias? Bias is the systematic deviation from the truth in the findings. And bias can occur due to several limitations in a study. For example, design, analysis, reporting, conducting of the study. And bias can lead to over or underestimated study findings. To rate the bias in the outcomes, we have to go back to the individual studies from the meta-analysis we saw before and to rate the risk of bias for each of those studies. And there are several frameworks that we can use for assessing the risk of bias for randomized controlled trials. And the risk of bias tool 2 is one of those frameworks. It's structured in 5 domains, which gives a really nice overview. And it's a very structured and complex toolbox that we can use to rate all of those studies. And we will rate them as being at high risk, low risk, or as having some concerns. So if an outcome is at high risk, this means that the study findings are less reliable and more likely to deviate from the truth. Selection bias. This is the bias that arises from the randomization process. So it assesses whether the allocation sequence was random or not. It assesses how the process was performed, for example, if it was computer-generated and can be trusted. But it also assesses if there were important baseline difference between the group that can suggest the problem. And the information of the randomization process was often not given. So this is why most of the studies had some concern of selection bias. Performance bias. This is the bias when there are deviations from the intended program. So bias can occur when the providers or the participants are not blinded. This might affect the intervention. But blinding the participants and providers is very difficult in some contexts. In the context of prevention programs, we have not found the ideal way of blinding participants and providers. And performance bias can also occur depending on which analysis we use. But almost all of the studies were at high risk of performance bias. Next one, attrition bias. This can occur due to missing outcome data. When missingness in the outcome data is related to the outcome, so in this case to the injury, the missing outcomes, that can lead to a bias. For example, if those who had a new injury are all missing, there would be a difference between those missing and participating. But missingness of the outcome would not lead to a bias if the missing is just due by chance. But overall, half of the studies were at high risk of attrition bias. Detection bias. This is the bias in the measurement of the outcomes. The bias can occur if the method of measuring the outcome is not appropriate. So measurement instrument should be valid and reliable and responsive. But this is a total different lecture that I have not to give today. What you have to know is that the outcome should be detected and classified with a valid and reliable tool. Bias can also occur if the outcome assessor is not blinded, because this could lead to a difference in the outcomes in the measurement of the injury between the different groups. And bias, this also depends on the expertise of the assessor. How often does he assess the injuries? Is it once a year? Is it every week? Is it self-reported? So overall, about half of the studies had detection bias. Reporting bias, last one. This is the bias in the selection of the results. It can occur if the results are omitted based on, for example, their significance or magnitude. To assess this bias, we have to know if there was a plan on how to analyze the data before the data were available. And then we have to know, was the plan followed, and was the analysis occurring to the plan, or were they cherry-picked? And 3 out of 10 were at high risk of reporting bias. So overall, most studies of those studies are at high risk of bias because they're at high risk of at least of one of those domains. And mostly this was due to performance bias that occur due to not blinding providers and participants. And although a study can be done in the best possible way and have good methodological quality, the outcomes can still be at risk of bias. So a certain risk of bias in the outcome is very hard to avoid here. Okay, let's look at the reporting of the program. So here I will only present the programs that we saw before, FIFA 11 Plus and the knee control program. So there are several lists to use that can help us to make sure that the programs are reported in a way that they can be reproduced. To improve the completeness of reporting, an international group of experts have developed the template for intervention, description, and replication checklist and guide, so the tidiest, but there are also different ones. This is based on a Delphi survey and expert consensus. And they present a long list of items that should be followed to ensure the completeness of the program, of the reporting of the program. And interestingly, they also included name, and name that can have an effect if you call your program is performance enhancing or something a little bit more negative. So it can be more attractive or less attractive. And I try to summarize the items in big categories to make it a little bit easier to guide you through. So first we have the rationale, or the theory of the elements that are essential to the intervention. Then we have the program delivery, so the details on how the program was delivered. This can be who provided it, to whom, and how did they do it. Then we have the details of the exercises. This is the different sets and repetitions. Where was it done? Were there any variation? Was there any progression? And then we have the details of adherence, so the degree to which an intervention happened and how it was intended to. So both studies included female soccer players in the original studies, and while the FIFA 11 Plus was mostly aiming to prevent lower limb injuries, the knee control was more targeting to reducing ACL and knee injuries in the start. But both targeted youth and adolescent team sports. For the FIFA 11 Plus program, the rationale was justified by data from studies on the mechanisms of anterior cruciate ligament injuries. And the main focus was to improve awareness and neuromuscular control during standing, running, planting, cutting, jumping, and landing. The rationale of choosing different exercises for the knee control program was that lateral trunk displacement and excessive dynamic knee valgus have been found to be risk factors for this type of injury. So we do not have a rationale for each of the exercises, but the rationale was to target the injury mechanism, which involves knee valgus and trunk displacement, as we saw before. And this is probably because we are missing also effect studies that show how does each exercises affect the movement pattern. How was the program delivered to the athletes? So in both studies, the coach and the team captain were invited to a pre-study instructional meeting to get detailed explanations of the program. The meeting took 3 hours, and after the meeting there was a practical session, and their trained therapist instructed on proper technique and also instructed on how to process to the next exercise. Concerning the material used, they used CD-ROMs and also paper forms with text and pictures. It could be poster or booklets. And now they have online links and apps. And in both studies, the program was led by the coach who instructed the entire team. So details of the exercise program, such as the dosage, they were given during the meeting, and I will not go into detail of each set and repetition for each program. Both programs were done on the court, so in a practical session, and they didn't involve material. Both programs start with a running warm-up of about 5 minutes, and then 6 specific exercises. And each exercise has 4 to 5 progressions. And the athlete should start on the first level of difficulty and could then proceed to the next level of difficulty if the coach deemed it as having good control. Both exercises also had a partner exercise to give a little bit more variation. And for the FIFA 11, the exercise should be done at every warm-up, and for knee control, it was instructed to do it twice a week at least. Okay, here are some exercises for the FIFA 11 Plus program. So in the first one, we see a running warm-up with some direction changes where someone has to circle the partner. Then we have the eccentric hamstring exercise to strengthen the hamstrings. Then we have the single leg stance. This is a neuromuscular exercise where you have to stabilize the knee while moving the upper body. And then some jumping and landing exercise where you have to control the landing to avoid landing with a stiff knee and having good control of the knee. So FIFA 11 Plus focused mostly on core strength, leg strength, balance, and agility. Then we have the single leg, for the knee control, we have the single leg squat, is moving the other leg. The pelvic lift to strengthen the hamstrings. Then we have the two-legged squat. And then we have the bench for some core exercise. And then the last two exercises show a variety of jumping and landing exercises. Here you can see some landing exercise with direction change, with some rotation. Then some partner exercises also on the court and involving football. And then we have a more fun partner exercise with jumping, some contacts, and landing. So who assessed the adherence to the program? In both cases, the adherence was assessed for the team and the player. And it was the coach who assessed the adherence. And the adherence reporting can differ whether it was the coach or the player. And adherence has also different dimensions. So it involves not only the frequency of how many times the program was delivered, but also the numbers of repetition, how many repetitions were done by the player, for example. This refers to the exercise fidelity. And in the original article of both programs, the frequency of the programs that were delivered was reported, but there were less details on exercise fidelity. And also we don't know about the movement quality, on how were those exercises performed. What was the planned or delivered strategies to maintain the adherence to the program? For the FIFA 11 Plus, the researchers contacted the coaches regularly by email and telephone. And for the knee control, study therapists are encouraged to contact teams with low compliance to motivate them. So both had strategies trying to enhance adherence. So overall, the reporting quality of both programs were good according to the checklist used. We can also say that the checklist, we have to remember the checklist, they came out after the original studies. So it was very well reported. What is lacking is sometimes a little bit more the clear rationale of each exercise. And as I said, this is challenging because we don't know so much about the effect mechanism. So how does the exercise change the movement pattern is not yet known yet, or well known. The implementation, or the process to transfer knowledge of the programs. And again, we will look into the FIFA Plus and the knee control program. Who does the exercises? Here you can see team compliance throughout the season in percentage. And you can see they start quite strong in the beginning, but there is a drop throughout the season to 58%. And at the mean, 3 out of 4 sessions were done. This is similar to the player compliance, where 79% was reported. But if you take into account player compliance and team compliance, then we can say that a little bit less players, each player, because they were not always attending the team. So the overall compliance is a little bit lower. Here the team compliance for the knee control program, and the results are similar to FIFA 11 Plus. Overall, you can see a significant deterioration throughout the seasons. Here they started at around 75%, and you can see the dark dotted line. This is the low compliance group, and this line here is the high compliance group. And you can see that the deterioration is a little bit, it drops more for the low compliance group compared to the high compliance group. And this decrease, so it looks like here that some are it's fairly stable, some are consistently continuing, while some just stop. And this can also reflect the decreased motivation among the coaches of using those programs throughout the season. The player compliance, this is very similar. We see a decrease. And here the decrease in the player compliance in the later phases here can reflect a decrease of player attendance at the training sessions over the season. And then here is a 3-year follow-up after the knee control program. And you can see that 35% of the original coaches continued using the program at least once a week. But if you remember, it was instructed to do at least twice a week. So there is quite a drop. And only 23% of the still active coaches were using the program without modification. So the fidelity to the program is very low. So there's a lack of maintenance of this program throughout the time, and this is a concern. What do the programs have in common? So they work. They're also largely delivered. If you remember that the compliance at the start is pretty high, but the compliance is low throughout the time, in coaches and in players. What were the implementation strategies that were used for FIFA 11 Plus and knee control? So both studies used a 3-hour workshop with instructions and educations to the team captain and to the coaches. And they also used supplementary resources like CD-ROMs and paperwork. They didn't use in a big extent on-site follow-up. And this has also been shown. So 3 randomized controlled trials have shown that weekly physio follow-ups did not have an additional effect. So this might not have helped to increase the compliance. How can we ensure compliance? So here we need a better understanding of the implementation context. We need to understand the end users, so the players and the coaches. And we need to look at the barriers among the end users that can reduce the implementation success. And there are several barriers. First, we have a reduced support and buy-in, so engagement, and that can be at different levels, player and the entire team and coaches, and that can impact the implementation. Then we also have lack of awareness and knowledge of the benefits of the program. Those are also major barriers that were reported. And then time restriction was one of the most common barriers. This can be a lack of time to learn, but also to instruct the program. In athletes, we can see a lack of motivation and boredom with the exercises. And then we can also see a lack of sport-specific exercises and a lack of variation in the exercises. And those can lead to a lack of motivation. And because of these barriers, the exercises are not experienced as attractive and applicable enough. So we have to integrate what we call facilitators for successful implementation. What can that be? So it should be support. Coaches need support from multiple stakeholders because they cannot take this all alone. Coaches would also benefit from workshops from trained instructors about the program. They also need evidence-informed educations on the benefits of the program to increase knowledge and awareness. They need also better accessibility of researchers that could help successful implementation. And then the program developers should also consider more enjoyable and user-friendly exercises that could include sport-specific activities. And increasing variation also can increase intrinsic motivation in the players and coaches. So for the injury prevention program to be effective in the real world, we need to involve the context and improve the content. To involve the context, we need to listen to the coaches and respect their needs, knowledge, and expertise. Because if the end users are not engaged initially, their knowledge is not implemented to the full potential, and then the exercises are often modified because they just don't fit the context. And to improve the content, the exercises should ideally be fun and sport-specific and individualized and challenging. And this will enhance both the players and the coaches' motivation with the program. So to involve the context, we need to think systems. We need to understand how the elements related to the prevention program are under control of different actors, as you can see here. All those are important actors that can influence the implementation of the programs. They relate to the athlete at different levels, so this can be individual, social, or structural. And you can see that the level of responsibility is increasing to the outer circle. So the player and the coach's perspective, they have responsibility, but also, for example, the sports clubs. One initiative to improve the content is, for example, the Get, Set app. This is an online support with sport-specific exercises. It's a website and an app. It's based on current prevention research from around the world. And the Get Set app was developed in cooperation with Olympiatoppen, so the Norwegian High Performance Center, and the national sports federations. And including the federations is also a way to involve different actors from different levels. It covers exercise programs from 30 Olympic summer and 15 winter sports. And in the app, you can choose different sports, but also different body parts. So you can choose the body part where you want to prevent injuries from occurring. And there are 3 levels of progression and a variety of exercises. And all the prevention exercises are presented with an instructional video. The exercises also require minimal equipment and can be done anywhere. So now we understand a little bit better the intervention context of both programs, and we have also covered how it can work in the real world. But to get an even better idea on what works in the real world, I just wanted to show you one more study. This is a descriptive epidemiologic study, which is covered by step 6 here in the TRIP model. This is, again, a study from Sweden that evaluated the effectiveness of knee control in reducing acute knee injuries in soccer players at a national-wide level. So the program was developed in 2005, and the structured education program to educate the coaches and also the soccer players has been implemented nationwide in Sweden in 2010. In this study here, they looked at all the licensed soccer players in Sweden, so all age, performance level, different sexes. And those athletes, the licensed soccer players are all covered by the same insurance company. So by using the insurance database, the annual incidence of knee injuries, but also cruciate ligament injuries, could be calculated. And then to evaluate the education and implementation nationwide, a questionnaire was sent by email to keep to the people who were working with the program within different districts in Sweden. And they showed a decline in cruciate ligament injuries and also in acute injuries throughout the years. And you can see here 2010, the implementation, and this was until 2015. So the incidence of knee injuries decreased by 8% in male players and by 21% in female players after the implementation. So the decrease was larger in female players. And the change in injury rate was probably related to the implementation of the knee control program during the time period of the study. But there's no similar decrease that was seen in other common team sports during the same period. So the results indicate in a way that the implementation has a preventive effect on the rate of the injuries. But we cannot attribute causation because there are many factors that can influence the incidence of injuries. So as the amount of exposure or duration and frequency of training, and also matches and game intensity. So to conclude, to maximize athletic knee joint health, what have we learned? We know the black box works. Injuries can reduce by up to 60%. The program should involve multi-components and especially plyometrics. And also we have programs with good reported interventional quality. We have also a study of good methodological quality, but the risk of bias in the outcomes does remain. And then if injury prevention is a complex problem, it probably requires a complex solution, meaning that multiple actors need to work together and to share the responsibility to prevent the injuries. And this also means that multiple solutions probably exist, depending on the level of sports, club culture, and coaches' knowledge. So you have to involve the content and to improve the context. Thank you.
Thank you, Anouk. Then we open up for questions from the opponents, if you have any. Sophie?
Yes, thank you very much, Anouk, for a great lecture. I wonder, could you elaborate a little bit more on the dose-response relationship of the exercises? How much do a player need to do the exercises to get the injury preventive effect?
This is a really good question, and I don't have the black and white answer. I think what we know is there is a dose-response relationship. The exercise have to be probably in a high amount to be effective, probably not as high as it was reported, as we can see a good effect throughout the time. But I can't say how much they have to do it, also because there is a lack of reporting in exercise fidelity, in the quality, in the repetitions. So I don't think we really know how much the athletes actually do the exercise, so we can have a strong conclusion based on that.
Thank you. It was a great lecture. I really enjoyed it. So I got stuck a little bit on the last part. It's a complex issue, with and a complex solution. If I do something called retro engineering, which means that in Amazon they do this. They say, like, what do we see in 10 years? What would be possible then, and how would we engineer that? So with all your knowledge that you acquired today, how would you make the best effective prevention program for each individual, each sport, to minimize knee injuries? How would that look like, and why?
I think I would not start the way on starting an efficacy study and see if the program works. I think I would start to seeing what is possible to implement, what would athletes use and the coaches use. So I would probably do a different way. So to look at the effectiveness implementation study for different situations, because they have to use it in order to work. So I don't think we have, so I would go the other way around.
Could I ask a question as well? Thank you for a very good and comprehensive lecture. I was wondering about these studies. How are they long-term follow-up studies? So when you're talking about implementation, how many years are we talking about? Because we know there is a lot of turnover in coaches and also in the athletes. So are we asking the same coaches that have learned the programs, or who are they? Could you tell a bit more about the long-term studies that looked into implementation?
Yeah, there's studies from knee control, and they looked into they had different coaches, so they had the old coaches and new active coaches, and there was the new coaches were also using it. I don't remember to which extent, but that was also at 3 years, so there were also new coaches who were using the programs, but we saw that it's quite a drop. I don't have any other long-term studies popping up right now, but the last study in Sweden, that was over a very long time, so they implemented in 2010 and they looked after 5 years. So that looked like it was implemented in a way that the decrease was over the 5 years.
Okay, thank you.
One last question for me. That's a little bit the same as Christian's question. What do you think about the implementation perspectives? How much is transferable to other sports when we look at papers from football, for example? What are sport-specific factors and what can be transferred to other settings, you think?
I think it has to be very individualized because it really depends on the different contexts. It depends on the different sports, and it depends also on the different coaches in the different sports. So I think we have to think a little bit more individualized. At the same time, we can also, for example, the follow-up of a physiotherapist in the teams was shown to not be optimal. But this can also be optimal in different contexts where the lack of support. So it's really individual. Also, there were studies on the only online resources that saw that this was maybe not as effective as it's all alone, where other studies found that could be good implementation. But I can't say which one fits best to which one. I think you have to individualize to the clubs.
Thank you. We're finished.
I would like to thank the candidate for her lecture and invite everybody to return to the auditorium at 1 p.m. Provided that the examination committee finds the trial lecture acceptable, the candidate will then defend her thesis after a decade of the Delaware-Oslo ACL cohort treatment algorithm. Measurement properties and outcomes after reconstruction or rehabilitation alone for anterior cruciate ligament injury. Thank you and welcome back.